Now let's talk pediatrics. High stakes, fast time. Pediatric respiratory distress is one of those things you respect like a storm on the horizon because children can compensate and then crash hard. In pediatrics, the airway positioning matters. Infants should be in a neutral head position without hyperextension. Children are also neutral, but only slightly extended if needed. Suction secretions, vomitus, blood, as needed. During PPV, maintain a patent airway with an OPA or an NPA if appropriate and tolerated. Ventilation rates for infants and children are commonly higher than adults, often 12 to 20 ventilations per minute in many teaching references depending on situation, and sometimes one breath every 3 to 5 seconds depending on age and protocols. Avoid excessive volumes and pressures. Gastric distension is a big problem. It can impede lung inflation, cause vomiting, and increase aspiration risk. Choosing a pediatric BVM matters. Use appropriate size. Many teaching references emphasizes a minimum bag volume range for effective ventilation in children, and in general, you're aiming for just enough squeeze to see chest rise, not making the bag empty. Now, the early key to pediatric progression. Early respiratory distress, also called compensated, is still serious. They can progress to failure or arrest in minutes. In early distress, rate and tidal volume are still adequate, so assisted ventilations may not be necessary yet. You'll see increased respiratory rate, nasal flaring, intercostal and supraclavicular or subcostal retractions, neck muscle use, stridor, wheezing, grunting, seesaw respirations, and an alert child with attitude still left in the tank. Oxygen and prompt transport is key. Decompensated respiratory failure is when compensation is failing. Either rate or tidal volume becomes inadequate. Signs can include very high compensatory rates, cyanosis, decreased muscle tone, severe accessory muscle use, poor peripheral perfusion, altered mental status, grunting, and head bobbing. These patients need immediate intervention, airway positioning, suction, high concentration oxygen, nebulized therapies per protocol, and often PPV with oxygen. Respiratory arrest is when breathing stops or becomes ineffective, gasping with pulse present. Signs include respiratory rate under 10 or absent, irregular or gasping breath sounds, limp tone, unresponsiveness, slow or absent heart rate, weak or absent peripheral pulses, hypotension in older children. In children, cardiopulmonary arrest usually follows progressive respiratory failure. Treat aggressively and transport immediately. Airway obstruction in children, you should always have a high suspicion. Partial obstruction may show stridor, retractions, noisy respirations, crying, forceful cough, pink or slightly pale skin, but decent perfusion. Treatment principles: position of comfort, caregiver assistance, oxygen as tolerated, encourage coughing if appropriate, limit agitation, and rapid transport. Complete obstruction includes no crying or talking, ineffective or absent cough, altered mental status, cyanosis likely. Then you perform age-appropriate foreign body obstruction maneuvers. Pediatric emergency care principles: establish patent airway, head tilt chin lift cautiously, no excessive hyperextension because infant airways can kink. Avoid pushing soft tissue under the chin. If spine injury is suspected, always use the jaw thrust. Suction secretions, but keep it short. 3 to 5 seconds for infants and children to avoid hypoxia and vagal bradycardia. use properly sized equipment, and avoid deep suctioning in responsive kids with a gag reflex. If ventilations are needed, use appropriate adjuncts as tolerated. OPA in unresponsive without a gag. NPA if oral, not tolerated. But be cautious in suspected head trauma and be aware of adenal hypertrophy and bleeding risk. Some teaching references caution NPAs, especially in very small infants due to small nares and resistance. If you initiate PPV, use pocket mask or BVM with oxygen attached. Use a one-way valve for infection control. Choose correct bag and mask size. Seal over the bridge of the nose to the cleft above the chin. Two-handed seal is preferred, often requiring a second rescuer, but it's life-saving because ventilation depends on seal and just enough squeeze for chest rise. If they cannot tolerate a cannula or mask, blow-by oxygen can help. Keep it simple and non-threatening. Positioning. Mild distress kids may prefer sitting in a caregiver's lap. Unresponsive lateral recumbent if not needing PPV to reduce aspiration risk. Suction ready. If ventilating, keep supine. For supine restriction, towel under the shoulder blades can help prevent head flexion. Transport any pediatric respiratory complaint with evidence of distress should be transported to the appropriate facility, ideally a pediatric capable one. Specific pediatric conditions include croup, which is an upper airway infection with a hoarse voice, seal bark cough, and stridor. It's a slow onset with a low-grade fever, which is common in ages 6 months to 4 years. Your emergency care should include oxygen to keep the pulse ox 94 or greater, position of comfort, minimal disturbance, PPV if failure, CPAP sometimes considered if allowed. Cool night air can reduce swelling and the child may look better on arrival, so report the original severity. Epiglottitis is a life-threatening, rapid onset, high fever, drooling, tripod, toxic appearance, and stridor. Nothing in the mouth, no OPA, no suctioning, no fingers, unless completely unresponsive with no air movement. Oxygen is tolerated. Blow by if needed, minimal agitation, rapid transport, and ALS if it won't delay. These patients may need an advanced airway in a controlled environment. Pediatric asthma includes a detailed history, questions, duration, fluid intake, recent infection, meds used, when, what, how much, steroids, allergies, recent ED visits, ICU admissions, and ventilator history. Assessment, position, mental status changes, vital signs trending upward, tachycardia, then possible bradycardia late, dehydration signs, cyanosis of tongue and mucous membranes, auscultate entire chest because focal wheeze suggests foreign body while asthma is generalized. Treat with calm reassurance, oxygen to keep 94 or greater, PPV if needed, position of comfort, assist with prescribed inhaler, considered nebulized bronchodilators per protocol, and transport. Status asthmaticus is critical. Consider your ALS rendezvous. Now, geriatrics. They have less reserve and faster decompensation. Geriatric patients have diminished respiratory function already. Dyspnea is common. Any additional burden can overwhelm them quickly. Respiratory distress may be primary pulmonary or secondary to failure of another system like cardiac. Dispatch clues may be dyspnea or may be weakness, inability to ambulate, confusion, chest or abdominal pain, falls. Use response time to prepare your brain. Common causes include pulmonary edema, pulmonary embolism, pneumonia, acute coronary syndrome, and COPD. Pneumonia risk factors include age, advanced, bedridden or institutionalized, immune compromise, other pulmonary diseases, cancer, prior stroke, poor detention, and inhaled toxins. Signs include increased rate, progressive dyspnea, dyspnea with exertion, congestion, cough, possible wheeze, malaise, altered mental status, and in severe cases of hypotension, dehydration, dull percussion, increased fermentus. In the elderly COPD patient may already be on home oxygen. Continue oxygenation and titrate as needed. They may have a baseline pulse ox of lower than normal, but you still treat the patient and target oxygenation per protocol. If 94 or greater, often 94 or greater unless known COPD titration guidance is used. Geriatric assessment is similar. Scene size up, primary assessment, then secondary. But remember, geriatric patients often have less time between distress and failure. Early distress signs in geriatrics include accessory muscle use, retractions, tachypnea, tachycardia, nasal flaring, mouth breathing, prolonged exhalation, cough, cyanosis, anxiety, and inability to speak in full sentences. Failure signs include altered mental status, vital changes, irregular breathing pattern, core cyanosis, loss of tone, diminished breath sounds, decreased response to pain, inadequate tidal volume, and retractions. Emergency care. Reduce anxiety, position of comfort, oxygen via nasal cannula titrated to maintain pulse ox target, PPV with oxygenation if inadequate breathing. And a major point about pulse ox. COPD patients may live at 90 and function, so context matters. But if they are in distress or failing, you treat the physiology. If the pulse ox doesn't rise with oxygen, worry about ongoing hypoxemia and gas exchange disturbance. If you remove oxygen and they drop severely, that tells you oxygen was propping them up. Use baseline readings if you can get them, but don't delay care to chase perfect numbers. If the patient is breathing fast but shallow with a pulse ox of 88, you should ventilate because the rate is not the same as effectiveness. Ventilation is about tidal volume and gas exchange, not just rate. Assessment-based approach. What you do in order. Now we pull it together with an assessment-based approach. Information from dispatch may be your first clue. Scene size up matters. Seek clues, trauma or medical. Look for mechanism of injury. Scan the environment. Your primary assessment includes general impression, mental status, airway, breathing, and circulation. Your general impression in respiratory distress is huge. Look at posture, tripod or supine. Look at facial expression. Listen to speech, full sentences or not. Check mental status. Look at neck muscles or intercostal retractions. Look for cyanosis, diaphoresis, pallor, nasal flaring, and pursed lips. Mental status changes. Restlessness, agitation, confusion, unresponsiveness, often accompanying difficulty breathing. Airway. Look for an obstruction. Is it complete or partial? Breathing. Look for rise and fall. Listen and feel for airflow. Auscultate quickly. And if chest isn't rising adequately, or you do not hear or feel adequate exhalation volume, begin PPV with oxygen. If rate or tidal volume is inadequate, ventilate. Shallow breathing is inadequate breathing. If breathing is just adequate, administer oxygen to maintain a pulse ox of 94 or greater, guided by protocol and patient presentation. Circulation. Inspect the skin and the mucous membranes. Your priority. Breathing difficulty is high priority. Consider ALS intercept. Transport quickly. For severe distress, failure, or arrest, do your secondary assessment en route. Signs warranting expeditious transport include inadequate breathing, irregular pulse, tachycardia, bradycardia in newborns with breathing difficulty, altered mental status, and cyanosis. Secondary assessment. If responsive, history using OPQRST. If unresponsive, rapid physical exam and other information from bystanders. Tie signs and symptoms to common causes. History questions include allergies, medications, and whether they've already taken meds. Bring meds to the hospital. Ask about pre-existing respiratory or cardiac disease. Ask about prior hospitalizations and recurring episodes. Physical exam. Posture. Cyanosis around the lips, nose, and mouth. Neck for JVD, tracheal deviation, and retractions. Chest inspection and palpation for retractions, asymmetrical movement, subcutaneous emphysema. Auscultate for quality and for wheeze, crackles, and rhonchi. Vitals. Watch for pulsus paradoxus. Heart rate may be fast or slow. Pulse ox under 94 is concerning. Under 90 is significant. If breathing is adequate, oxygen to keep at 94 or greater. If inadequate, ventilate. Remember, the severity of shortness of breath doesn't always correlate with hypoxia. Some patients feel awful with decent oxygenation, and some look calm and are profoundly hypoxic. Your assessment must be objective. Emergency medical care. Don't waste time trying to nail the exact cause unless trauma demands it. Your immediate decision is simple. If inadequate breathing, open airway, adjuncts if needed, PPV with oxygen, and rapid transport. If adequate breathing, oxygen based on pulse ox and presentation, baseline vital signs, determine an MDI or an SV in use, contact medical control, or follow local protocol, position of comfort, and transport. Reassessment. Did your care improve distress, or are they deteriorating? Monitor airway, pulse ox, pulse, recheck blood pressure, recheck breath sounds, repeat vitals if complaint changes, consider ALS if not responding. And here's the hard truth. Signs can be missed when EMTs get distracted, rush without looking, fail to auscultate correctly, or get falsely reassured by one number. The key to recognition is a disciplined routine. Look, listen, feel, measure, compare, and reassess. So let's wrap up. Let's close with big takeaways. Normal breathing is an intact airway, normal rate and rhythm, good chest rise and fall, clear bilateral breath sounds, minimal accessory muscle use, normal mental status, and skin findings. Abnormal breathing can come from airway obstruction, lung disease, poor perfusion, or impaired gas exchange across the alveolar capillary membrane. Respiratory distress means breathing is difficult but adequate. Respiratory failure means rate or tidal volume is inadequate. Respiratory arrest is cessation of effective breathing. Breath sounds guide you. Wheezes suggest lower airway narrowing. Rhonchi suggest secretions. Crackles suggest fluid involvement. Obstructive diseases, emphysema, chronic bronchitis, asthma share airflow limitation but differ in presentation. Treatment goals remain: maintain airway, support oxygenation and ventilation, reduce work of breathing, and transport. Other causes: pneumonia, pulmonary embolism, pulmonary edema, and SCAPE, S-C-A-P-E, spontaneous pneumothorax, hyperventilation syndrome, epiglottitis, pertussis, cystic fibrosis, toxic inhalation, viral respiratory infections. Each has key patterns, but your first move is to stay the same. Oxygenate and ventilate appropriately. Pediatrics can compensate, then crash. Geriatrics often have a little reserve. Both groups deserve your respect and speed. And finally, respiratory patients demand reassessment. This is not a set it and forget it call. If they worsen, you escalate. If they don't respond, you reconsider. And if you're in doubt, you treat hypoxia.